edema, you think of the major three organs, the heart, kidney, and liver. You screen them. Patient whose heart problem with the heart causing lower limb edema usually doesn't involve the face, but the two, liver and the kidneys, they can involve the face. But if the liver is like having a compromise to cause lower limb edema, there have to be other things like ascites and stuff like that. But it's the kidneys, for example, when it has a problem, it just can be there with edema and the patient is going on with their own life. And when we talk about the kidney, two things: late kidney failure or nephrotic syndrome, in each patient will be losing protein in their urine. Doesn't matter whether the urine is frothy or not. At the end of the day, we have to check the urine of the patient. So the previous history of lower limb of diarrhea 3 weeks ago, and patient went to the hospital, given a certain medication. That's also important because there are medication that patient was given can be a culprit, but this maybe it is not a disease of 5 days. Maybe it's a disease of 3 weeks, not being noticeable now, being noticeable in the past 5 days. So that's why also we will consider that in our back of our minds. Let's proceed because of time, David.
Okay, so I'll just do a quick summary of what we are talking about. We have a 19 years old male who presented with volume swelling for 5 days, and Joseph was going through this case. The patient, the lower limb swelling was persistent, involving both lower limbs. It was painless and associated with an episode of morning facial swelling. And he had a history of a diarrheal illness, which was associated with fever about 3 weeks prior to presentation. But he had no history of difficulty in breathing, awareness of heartbeat, chest pain, waking up at night due to air hunger, frothy urine, blood in urine, reduced urine output, yellowish discoloration of eyes, abdominal pain, nausea, vomiting, or bleeding from any sides. So the review of systems was unremarkable. Past medical history was non-contributory, and this was the family social history. He's a Form 4 student, lives with both parents, no alcohol, smoking, or recreational drug use, physically active, cycling and playing soccer daily, and there is history of hypertension in paternal grandmother. So, Joseph, from these other components of the history, before we go to physical examination, do you have anything else?
Nothing else.
Okay, so we'll proceed to physical examination. So on general examination, this patient was fully conscious. He was a febrile, not pale, not jaundiced, not dyspneic. He had no lymphadenopathy. He had bilateral pitting ankle edema. He had no facial swelling at the time of presentation. And the vitals, the pulse rate was 98 beats per minute. Blood pressure was checked on both upper limbs. The right was 165 systolic and 101 diastolic, and on the left 163 systolic, 110 diastolic. He had a normal BMI. Other vitals, the respiratory rate, the temperature were, and the saturation were normal. And systemic exam on cardiovascular system, he had regular rate and rhythm, synchronous pulses, both upper and lower limbs, no raised AVP. He had a normal precordial exam with no murmurs and no displaced apex, no abnormal findings. Abdominal examination had a normal contour, no tenderness, masses, or bruise, and other systemic examination was normal. Back to you, Joseph.
Okay. Can I see? Okay, yeah. Yeah, so thank you very much. Yeah, that's pretty interesting because I said we'll be solving a problem of lower limb edema plus fascial edema in the morning. And yes, that's what the general exam being shown here. Of importance, this is a young person of 19 years old male, and he has hypertension, 163/110. So what we'll be doing, because this is pretty much unusual, and what we'll be doing is we will term this hypertension as secondary unless there's proven otherwise, which means we'll screen everything that we think might be causing secondary hypertension in a young patient, and unless maybe we don't find it, we can say, okay, maybe it's just like, because it happens also. I've seen patients young screen everything and then it's okay, and they ending up with just with just a primary hypertension. Can I see the systemic exam? Okay, yeah. So the systemic exam is normal. So I think my job now will be to think of a secondary cause of hypertension that can also present with lower limb swelling. One that comes easily is hyperthyroidism, for example. Hyperthyroidism can cause secondary hypertension, but also patients with hyperthyroidism, they can come up with lower limb swelling. Hyperaldosteronism can cause secondary hypertension, but I don't think as if it causes also lower limb swelling. Other causes like aortic coarctation, chronic kidney disease, they can also cause hypertension and also cause lower limb swelling. But so I think that's how I'll be going with the case, trying to figure out anything that can cause elevated blood pressure in a young patient, and again at the same time presenting as lower limb swelling. So far, not much, and I think I have to see maybe David the labs.
Okay, let's go to the labs. So preliminarily, this is what we had. So the RBG was 5.1, creatinine 95.7, which was within normal limits. BUN also within normal limits. CBC was normal. Albumin 4.39. Liver enzymes, lipid profile, triple serology were negative. And on the right here, we have the urinalysis. So as you can see, Joseph, maybe you can take note of whatever you think could be of help. And I think you can discuss these ones and discuss any further steps that you would take.
No, muted. Okay. So I'm having difficulty because I'm using the phone. It means everything is normal around here, right? This creatinine, this albumin, these are normal.
Yeah. So basically, for the chemistries that are there is nothing abnormal there.
Yeah, and the urine doesn't have protein. Okay, so normal labs. Yeah, so in solving any case, it's not just about arriving at the diagnosis, defining the problem. I'm still thinking, what problem should I be solving here? Because I tried to solve secondary hypertension, but still, I think that won't be. Anyway, if it's okay, I can go again. But the case is, the problem here is it's a patient who was sick with a febrile diarrhea 3 weeks ago. 3 weeks ago, yes. And then in this week, 5 days ago, is presenting with just lower limb edema without any other symptom. And the exam is just unremarkable, except that they have edema, which they've told us. And then I thought when I see the labs, I can have some glimpse, especially with the chemistry, which is everything is normal. So if there is no protein, so we go back to the basics. Say it's either of the two things in this patient, because there is nothing which shows the patient is inflamed. They have to be losing protein from somewhere, or they have to be having a very high pressure in the intravascular system. Losing protein from where? I thought they're losing protein from the urine, for example, and maybe they're having nephrotic syndrome. But as we see, the urinalysis, that's not the case. Not just that, but even the albumin also, because albumin, two major proteins in the blood, albumin plus immunoglobulins, and if they're losing protein, we have to see albumin in the blood low. If they're losing it through the urine, we have to see the urine with the proteins, but which is not the case. Are they losing it through diarrhea with protein losing enteropathy? Again, less likely, because that was 3 weeks ago. And then even if they lost albumin through the GI, the albumin in the blood have to be low. So maybe that is out of the question. That shouldn't be even considered. Now we consider does they have an elevated hydrostatic pressure? Maybe, but we don't see anything else suggesting that. We don't see anything else suggesting that. Elevated hydrostatic pressure. Diseases that will impair the normal flow of blood, like patient's heart is failing, completely out of the question again, because there is no other symptom. Liver, it can't go to this stage without having any other symptoms. So maybe if there is something causing increased hydrostatic pressure, it's not among those. So it's something else which maybe we don't see usually. But as I said, thyroid diseases should be considered, and that's the thing I will send, because I don't see them here. I'll send the thyroid function of the patient and to see. But if I go to the question of is anything that I know which happened 3 weeks ago, and today we are seeing the result of that, maybe the medication that we are given. It is known, yes, there are medications. Even if you see, for example, you're seeing patients in outpatient department, and then most of them will come with lower limb edema, and usually there's no cause, but you find out it's usually the medication, the culprit. You find the medication. They're given some medication they call lower limb edema. But that again will not explain why is this patient having not having hypertension. So other kind of lab will be sent to screen for the secondary hypertension, not just lab, but even the imaging. For example, renal artery stenosis. This is something which will need imaging. Other labs will include there is a lab we send to look for the tumors of the suprarenal gland. For example, I think that urinary metanephrines. Yeah, so David, I'll be there, but still, I can't keep my head.
Joseph, you've
around. Honest.
yeah. So maybe can you summarize this case just briefly for anyone who came while you were discussing?
Yeah, it seems a simple case but difficult to solve. It was of a 19-year-old boy who presented with just lower limb edema with 5 days ago. Also reports some episode of fascial swelling in the morning. He had a diarrhea 3 weeks ago, which was serious fever, and currently no any other symptoms. There is no difficulty in breathing. Just on the exam, there is lower limb edema, and the blood pressure is high, 160 to 110. Yeah, and the labs that's shown here are pretty normal.
Yeah, so you said you loaded some more labs as well as imaging. Yeah, so we had some other labs, including electrolytes and an abdominal pelvic ultrasound, which was reportedly normal. But here we have electrolytes, sodium, potassium, as well as calcium. Now, with these extra pieces of information, is there anything else that do they help you make any progress, or is there anything else that you need to do for this patient?
Yeah, so for example, the yeah, so for example, the hyperaldo, the case of hyperaldosteronism usually present with hyponatremia. But what I'm seeing, the sodium of the patient is normal, the potassium is normal, the calcium is normal. So yeah, so something like that I think is be low on the list, but still I would need the TSH in the patient. Yeah, is there anything else?
Yeah, so about these electrolytes, so maybe if you can, for the people in the crowd, what do they help you rule out mostly? You talked about hyperaldosteronism. What would be the picture that you were expecting?
Yeah, and I can see. Okay, now I can see. For personally for hyperaldo, I expect it to cause hyponatremia and hyperkalemia, if I'm not mistaking them.
Yeah, it
Uh,
should be the reverse. So hyperaldosteronism will cause hypernatremia and hypokalemia.
uh-huh.
Yeah, it's so adrenal insufficiency will cause what you mentioned earlier,
Yeah,
will
okay.
cause
Sure.
hyponatremia and hyperkalemia.
Yeah, sure. Yeah, you're right. And now to cause hypernatremia in a patient who is alert and awake and could access water would be hard. So if you don't see that, maybe the hypokalemia, which is also not there.
And regarding this ultrasound, uh, does it help you rule out any differentials that you are considering, and maybe which ones specifically?
Yeah. So, for example, I was thinking of because of secondary hypertension, the renal artery stenosis, but I don't expect that to be ruled out through just a normal abdominopelvic ultrasound. It has to be a special kind of ultrasound, not just abdominopelvic ultrasound.
Yeah, so we have some extra pieces of information. So this is for the renal artery stenosis. Renal Doppler was done, and so I just wrote what the radiographer reported. there are normal peak systolic velocities throughout the course of both right and left renal arteries, but the radiographer reported high resistive indices. So does this click anything to you?
To be honest, I don't know how. Maybe I would ask what do they mean high resistive indices, because when I send there, I want them. It's renal Doppler is the imaging of choice to diagnose renal artery stenosis. So I have to ask. I've never seen such a result like this. That do they mean is there stenosis or not? That's what I would want.
Yeah, so for these, and I think we'll discuss this briefly later. So after they reported the high resistive indices, they suggested to do CT angiography and renal angiography, and basically it wasn't just renal angiography, but it was angiography of the aorta as well as all its branches, and it was reported to be normal. The angiography which reported the abdominal aorta particularly, but as well as the thoracic aorta, and then the branches including the renal was reported to be normal. So what are your thoughts at this point?
Yeah, so this is hard for me, but I think we are at the stage where we have we've tried to rule out some causes of secondary hypertension, and what are we remaining with in our buckets? So we've said renal artery stenosis out of the question. We've said hyperaldo out of the question. Aortic coarctation out of the question because of the angio that was done. Again, on the part of the endocrinopathies, still thyroid. I'm not seeing it, which can explain the lower limb edema and hypertension also. Not related to what happened 3 weeks ago. Do I have anything else? A pheochromocytoma usually doesn't present with such a picture. These are sick patients, but maybe it's possible. Someone can still send the metanephrines again. Yeah, so I'll consider hyperthyroidism because it can be silent like that, causing pressure, causing hypertension and lower limb edema and nothing else, which is still not sent. And I understand the metanephrines, they're hard to send. Sometimes maybe you don't send them unless you don't find anything. So if I was seeing the patient in the clinic, even in my position, I will send first of all the TSH and the T4 before needing the metanephrines, as they are hard to access.
Very interesting discussion, and I hope people are learning. So I see you are systematically ruling out things. So secondary hypertension, I think you're almost exhausting everything. And yes, for what you requested, so we ordered some more labs, including the thyroid panel that you talked about. It was normal. Serum metanephrines were done, which were normal, and then cortisol also was ordered, which was normal, and serum PTH was also normal. So this is the point where you commit to a particular diagnosis, or a list if you have any.
Oh, muted again. So this is where I have to commit, right?
Yeah. This is where you commit. So I had some more labs for you, and Here were the results.
Okay. Sure. I don't know if I have anything else here. So maybe let me think, because all the causes that we usually know, they've been ruled out as I am seeing here. Especially the endocrinopathies. But let me see, maybe maybe cortisol, but again, nothing else that say this can be Cushing.
And the
So,
cortisol is there. It's normal.
oh, okay, again, it's no.
Yeah.
Yeah, so I think everything I know, unless I'm forgetting, the list is it's long, maybe I'm forgetting something. So I'll go back to say, what was this patient given when he has diarrhea a week ago? What is the drug that can cause elevated blood pressure and edema? That's steroid, right? But I wonder why would anyone give steroid in a patient with diarrhea? That would be hard. Okay, maybe someone wrote a medication and there was a problem with the pharmacy. Maybe they were given a medication right there, somewhere, go and buy medication. And I have had that problem with a patient, but it's not this medication. You write this medication, and unfortunately, they're given another medication. You realize later it wasn't the medication. So the medication that I know, it causes hypertension and edema, is steroids. But if that was the case, then it was a mistake. I don't know. You have to teach me. That's where I am. I would say that though they have to be related with the medication they were given. I think maybe it was unfortunate they were given a steroid, but I can't tell apart from that, David.
Yeah, thank you for an interesting discussion, and I think you've taught us so many things. So I had the same. So I personally attended this patient, and all these labs that you see, I referred this patient to a cardiologist at some point, to an endocrinologist, and because I had close communication with them, I would send them for their opinion, but then with a list of investigations to be done, telling them what I've already done. Because so I attended this patient sometimes last year. I cannot remember exactly which month, but I had the same issues as you had, because once I saw, so this patient was seen by a GP, and then the GP referred the patient to a physician because of the hypertension. So once the patient landed in my consultation room, so I had to say, this is a 19 years old adolescent who is presenting with markedly elevated blood pressure. So the blood pressures are reading 163, 165 over 110. So, and as usual, popular teaching, and of course, that's the way we are supposed to go. I wanted to make sure that we rule out every possible cause of secondary hypertension that we can rule out. So, and I think a number of issues that disturbed me, the same as the same issues that you had, is I asked myself, is the current presentation that we are seeing? So when I was seeing the patient, all that was present, the patient had no facial puffiness, just lower limb edema, and on subsequent visits, even the lower limb edema wasn't there. It was just elevated blood pressures. So my question was, is the elevated blood pressure related to what we saw, or to what happened to this patient 3 weeks prior? So my thought was, maybe the diarrheal illness led to some renal dysfunction. If you consider a number of things, so there is a HUS. Someone can have HUS after a diarrheal illness, or maybe let's just say in general HUS, but maybe I thought maybe some glomerular diseases like a glomerulonephritis, which could explain hypertension, could explain edema, but then uh, just after seeing the urinalysis and the albumin and all other chemistries, that completely disappeared, that this cannot be a glomerulonephritis. You see the renal function test, you cannot talk about HUS, for example. And of course, in addition with the CBC, which was normal, there is no thrombocytopenia, no features in keeping with a TMA. So uh, so the question was, I so just after seeing the urinalysis and all the other labs initially, my thoughts were maybe uh, what we are seeing is not related to what happened 3 weeks prior. But then let's wake up this patient for secondary hypertension. So I did the labs I could, sent this patient to do these other labs. So a cardiologist, so an endocrinologist, and all these labs were done. Nothing revealing. So we ended up with, and about medications, I think if it was steroids, for example, and remember that was just a short course and of less than 5 days. Now in 5 days, it's not very common for steroids to cause all this presentation, and maybe after withdrawing the medications, because the patient is no longer on medications, we are seeing him 3 weeks later. And throughout the number of weeks that I worked up this patient and went to a cardiologist, went to an endocrinologist, the blood pressures were high, the edema has disappeared, and there is nothing else that is telling about anything else. So the thoughts were that we are dealing with primary hypertension in this patient, because primary hypertension in adolescents and children is a diagnosis of exclusion, and we try to exclude everything that we could think of, and so that is what we ended up with. So I have a few teaching points here. So testing for secondary hypertension is indicated when there is an unusual presentation of hypertension. And an unusual presentation of hypertension is when you have hypertension in someone who is young, younger than 30 years of age, and nothing else that is pointing in the direction of primary hypertension. So a young patient like this, 19, uh, a comprehensive evaluation to rule out secondary causes of hypertension was warranted. Another one is when there is drug resistant hypertension, or when there is presence of a clinical clue to a specific cause. So we had to wake up this patient for secondary hypertension, which was non-revealing. And so when we are talking of secondary hypertension, the commonest cause of secondary hypertension is renovascular hypertension. And renovascular disease, you are talking about atherosclerotic, renal artery stenosis, or fibromuscular dysplasia, especially in young patients like this one. So the guidelines are, because that is one of the things that we thought about, and of course Joseph also thought about renal artery stenosis, but the guidelines say you test for renovascular hypertension with imaging only if intervention is warranted, or if intervention can be instituted. And the gold standard for diagnosing renal artery stenosis is renal arteriography, which is an interventional radiology procedure. But then there are non-invasive alternatives which we commonly use, like renal Doppler, CT angiography, like the one that we did, which has some limitations in fibromuscular dysplasia, and magnetic resonance angiography. So we did renal Doppler, and all these non-invasive alternatives have some limitations that you need to be aware of. And I think that is another learning point, an important thing that I learned from this case, that they do have limitations, and I think it's important to have knowledge of the test characteristics in order to be aware of the limitations that you can come across. So, for example, for renal Doppler, even when you read up to date, for example, what they will tell you is that renal Doppler is an acceptable alternative in diagnosing renal artery stenosis, but then it carries some limitations, uh, including massive operator dependence. You know that with ultrasound there is operator dependence, and then another thing is that it has a very steep learning curve, and therefore people who are experienced will many times they will trust results from people who are very experienced in doing renal Dopplers and maybe not from other people. So, and I'm not a sonographer, but then when I read about how they report the results, I thought that those things were not telling, because if you are suspecting, and the conclusion of the radiographer was that the sonographer was that because of the high resistive indices, there is high suspicion of renal artery stenosis, and therefore they recommended CT angiography, which was done. But then the fact that we saw the peak systolic velocities, the peak systolic as well as diastolic velocities in both renal arteries were normal, it would be difficult to report high resistive indices, because the resistive indices are calculated from the peak systolic velocities, and therefore those things were not tallying. But again, CT angiography was done, which was unremarkable. So, about primary hypertension in children and adolescents, as I said, is a diagnosis of exclusion. But so when you encounter hypertension in children and adolescents, as we said, you need to do comprehensive workups to make sure that you rule out secondary hypertension. But again, it is the most common cause of hypertension in children and adolescents in countries that have data from those age groups, especially the US. And primary hypertension, or hypertension in general, is reported in about 4% of the general population of children and adolescents, and the commonest cause is primary hypertension. So, and the risk factors are the same as in adults. So you have the modifiable risk factors, including obesity, physical inactivity, and other things, and then non-modifiable risk factors like sex, more common in males than females, ethnicity, more common in blacks than whites, and then a family history of hypertension, which was present in this adolescent. So for this one, we did not have any other risk factors for primary hypertension. The patient was normal weight, physically active, and he did not have any risk factors that were in keeping with uh, primary hypertension, apart from a family history in a paternal grandparent. So the thought was primary hypertension, and this patient was started on medications, the usual medications. It initially losartan H, and a beta blocker because of the lower limb swelling in the patient. So a calcium channel blocker was avoided. So started on losartan H, and that was bisoprolol, if I remember correctly, 5 milligrams, and the patient's blood pressure normalized, which again would be a clue in making the diagnosis of primary hypertension, because many secondary causes of hypertension would not respond that easily to antihypertensive medications and just 3 medications. So that's what I had, Joseph. And I would also personally say that I was supposed to put a question mark on that final diagnosis, querying primary hypertension, because up to this point, although I think I've followed up the patient for more than 6 months, doing well on the 3 medications that I mentioned. The blood pressures are well normalized, but I'm still thinking, is there anything that we are missing as far as secondary hypertension is concerned? So that's what I had for you, Joseph. Any reflections from you?
Yeah, thank you very much. It's a good refresher on the causes of secondary hypertension. But yeah, I have patients like this. I even younger than this, and but it's a bias when you solve the case. Like, yeah, you think there are these you say, okay, David won't present hypertension. Have to be some um uh, rare diagnosis or something that is hard to figure out. But yeah, at the end of the day, that's the teaching that you've ruled out all other causes, and then it has to be essential hypertension. At the end of the day, you have to treat it. So yeah, it's an eye opener. Thank you very much. But still, again, on the if you think of the lower limb edema, if someone really sees patient lower limb edema, people come with lower limb edema in the hospital, and there is no cause. You do stuff and you find nothing. So yeah, thank you.
Thank you very much. And of course, that was another thing that I didn't touch on initially. The lower limb edema. Maybe a question comes that so what would explain the lower limb edema? Very difficult, especially with the facial puffiness. But with lower limb edema, although not a common presentation, some sources will tell you that hypertension itself, especially when it's very elevated, can present with edema. Now, here comes the question that so is this the hydrostatic pressure that we are talking about, or is it something else? But maybe the edema could be part of the presentation of the hypertension, but that was one of the things, especially the facial edema, very difficult to explain. But then we ended up with the diagnosis of primary hypertension, treated, and everything, even the lower limb swelling, is no longer present. So thank you very
Well,
much, Joseph, for discussing the case and for the reflections. We are just a few minutes past the hour, and so if there is anyone from the audience with any comments, any questions, or any suggestions on what else maybe we probably missed in the workup of this patient, that can be taken for improvements if we come across these patients in the future, please welcome. Yes, Fabian, please welcome.
Yeah, thank you very much. It was a very wonderful case. Thank you for the presenter. I was just asking, evaluating the secondary causes, coarctation of aorta. Was echo done or ECG? ECG in terms of looking if there is any sign of LVH or echo, see if you can rule out coarctation. Was there any echo done?
So echo, ECG were all done, and unfortunately, because I kept a like a file of the investigations of this patient. So when I was summarizing the case, I couldn't find them. But as far as I remember, they were unremarkable. They were unremarkable. So I do not remember, especially about the echo. I think my thoughts are contradictory, whether there was some LVH reported, but especially the ECG was unremarkable. So echo, I think either reported normal or some LVH, if I remember correctly, but otherwise, especially with nothing else was reported, and with the angiography also, the aorta was reported to be normal.
Okay, thank you, Doctor.
So anyone else with any questions, comments, any suggestions before we close the session? Yeah, so I do not see any hands. So the reason for me bringing this case is I think we all, I think we would all be very much worried if we come across a 19 years old with elevated blood pressures. And as we said, it's very important to screen for all causes of secondary hypertension, because in a patient of that demographic, primary hypertension will be a diagnosis of exclusion. So But the thought was just to shine light that it's possible, maybe for those of us who have not seen younger than 20 or 30-year-olds presenting primary hypertension. I think this could be an eye-opener that it's possible, and especially with the nutritional and epidemiologic transition. With even young people presenting with the traditional risk factors for non-communicable diseases like overweight and obesity, then on top of non-modifiable risk factors like a family history of these diseases, then maybe it will be it's something that's on the rise. And for those, I think there was a paper which was circulated in recent months after newspapers sometimes they can exaggerate things, and so this paper became famous, which is a local paper, and one of the authors is Professor Furia. They did a study among primary school pupils, I think, and some were found with hypertension, frank hypertension, and then a significant proportion with elevated blood pressure. So I think these are things that, especially those who are taking care of pediatric patients, maybe they will be increasingly seeing in the future, young patients with primary hypertension. So we just need to be aware that these are things that are out there. So if there is nothing else, it was good to have everyone around. We, as always, we remind those who have cases. So you see, today we presented a case of primary hypertension, although of course the diagnostic process very challenging, but you might have your cases that we can all benefit from. So please be generous enough to share with us the cases that you have, whether complete or incomplete. We'll share thoughts that will help us learn and also be beneficial to the patients. So having said that, have a good night and see you next Sunday.
Good night.